Welcome to our live webcast, Established and Emerging Treatment Strategies for AL Amyloidosis in 2021. Thank you for joining us. My name is Eric, and I will be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. On the right-hand side of your screen, you will see the text chat window. There is a large window which holds all of your sent messages, and a smaller text box at the bottom where you will type in your questions. To send a question, click in the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenter. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. We are joined today by our speaker, Dr. Heather Landau, who is a hematologist-oncologist and the director of the Amyloid program at Memorial Sloan Kettering Cancer Center, focused on increasing access to novel, effective therapies in AL amyloidosis and has investigated drugs at all stages of development. She has conducted multiple investigator-initiated clinical trials, exploring novel agents and approaches, including consolidation and maintenance strategies in high-risk patients. She led the development of MSK's outpatient transplant service and is studying innovative ways to optimize high-dose therapy and transplant care.
Thank you so much for inviting me here today to speak about established and emerging treatment strategies for AL amyloidosis in 2021. Here are my disclosures. Today we're going to speak about the pathophysiology and treatment goals for patients with AL amyloidosis, the standard of care approach before the current time, the new therapies that are exciting now in 2020 and available in 2021, second-line treatment options, and how we are going to improve care moving forward. So in terms of pathophysiology and treatment goals, what is amyloid anyway? Amyloid, the name comes from the word amylum, which is starch in Latin based on what a pathologist observed in postmortem tissue biopsies back in the day. And it's really a protein misfolding disorder. So here I show you a normally folded protein, which has an alpha helix structure, whereas amyloid is a normal protein that misfolds in a certain conformation, a beta-cleated sheet, and forms these insoluble amyloid fibrils, which allow it to deposit in various organs. And many different proteins can form amyloid. Today we're speaking about light chain amyloid, but it's very important to know what type of amyloid the patient has. So what causes AL amyloidosis? It's a plasma cell disorder, and plasma cells are made in the bone marrow, and normal plasma cells, shown here, are of two different types, kappa and lambda, and these plasma cells produce immunoglobulins or antibodies, and these are the light chain portions of the antibodies, and there's, in normal people and in healthy people, there's a mix of both kappa and lambda light chains. However, when there is a disease-causing plasma cell, there's a monoclonal proliferation, which means the light chains are identical and can be traced back to a single original diseased plasma cell. And now the antibodies that are made and the light chains that are made are only these lambda light chains, and these are the entity that forms the amyloid. Here I show the most common manifestations of AL amyloidosis. The periorbital ecchymosis, or bruising around the eyes, is pathognomonic for, and macroglossia is pathognomonic for AL amyloidosis, but only occurs in 20% of patients. This is the heart muscle, and you can see it's very thickened, and it causes a constrictive cardiomyopathy. It's different than our typical heart failure patients. which have left-sided heart failure. This is not pump function, it's really a problem of filling the heart. Renal involvement occurs is when the kidney is affected and the amyloid affects a specific part of the kidney, the glomerulus, and here's a normal glomerulus, and this is when it's disrupted by the amyloid proteins. The function of the glomerulus is to filter proteins and keep the good ones in and the bad ones out, but when the glomerulus is disrupted, you have loss of the majority of the protein in the blood. The liver is involved. It can lead to a large liver and symptoms of early satiety or fullness, abdominal pain. Neuropathy can present as a sensory neuropathy, leading to pain, numbness, and tingling, or an autonomic neuropathy where patients can have orthostasis or gastric dysmotility, leading to fainting or diarrhea or constipation. And the most frequent symptoms are listed here, and they're very common symptoms and often associated with other more common conditions, which is what makes it challenging to diagnose this disorder, which is a rare disorder. So what we find is that on average, patients visit 4 doctors or specialists before ascertaining a diagnosis. And with the Amyloid Research Consortium, we did a survey of 443 patients and their caregivers, and these folks named 220 cardiologists that actually missed their diagnosis. And this is a conundrum because late diagnosis has clinical implications. Cardiac disease is the main determinant of survival, and therefore staging, which is an assessment of disease severity, was based on cardiac biomarkers, which are able to measure organ damage indirectly. The main cardiac biomarkers being troponin and NT-proBNP, and in some places BNP. And you can see here, this is a chart of survival and time. If you look here, this is survival and this is time. And patients who have an abnormal troponin and NT-proBNP, the highest level, have what we call stage 3B disease, and they have a very short survival, whereas patients who have a normal troponin and NT-proBNP are stage 1, and their prognosis is much better. Patients with kidney disease are at risk for requiring dialysis, and the main kidney biomarkers that we use to understand kidney dysfunction is protein loss in the urine and the estimated glomerular filtration rate, which estimates kidney function. And you can see here that patients who have normal low levels of proteinuria or high or relatively preserved kidney function have a low risk of requiring dialysis, where patients who have high levels of proteinuria and low renal function are almost 50% of patients will require dialysis at 2 years. So the goal of treatment is to target the disease plasma cell clone, and once we eliminate the pathologic plasma cell, we can see the light chains disappear or reduce, and that's what's necessary in order to improve organ dysfunction. And when organs improve, we see the biomarkers improve, and it takes both a hematologic response and an organ response to have the most optimal survival. So here's patients with a hematologic response, and that is great for hematologists, but that doesn't necessarily make you feel better. You feel better when your organs improve, and that's what also prolongs survival. So our goal is to achieve both a hematologic and an organ response, and really the deeper hematologic response, the more likely you achieve an organ response. So how do we measure a hematologic response? That's by assessing the levels of the free light chains. And if treatment is working, the plasma cell levels, again, should decrease, which will reduce the levels of the circulating light chains. And we measure it by measuring directly these light chain entities which circulate in the blood. And we can see here that, again, this is survival and this is time, and patients who achieve a complete hematologic response, meaning absolute reduction of the light chains to a normal range, have the best response, and those patients who have a very good partial response also have a fairly good response, whereas patients who have a partial response or no response really do very much less well. And again, organ response depends on the depth of hematologic response, where complete responders will improve their organs more than very good partial responders or partial responders. And this category, MRD negative, this is a level of detection of the free light chain or the abnormal plasma cells by our most sensitive markers. And those who achieve MRD negativity, meaning minimal residual disease negativity, meaning we can't detect a free light chains or plasma cells by our most sensitive method, have the highest likelihood of improving their organs. However, organ responses take longer than hematologic responses. So once we get a hematologic response, we have to often be patient in order to continue to assess the degree of organ improvement, if it's going to happen. One thing that is notable is that patients, even once they have a hematologic response, some practitioners will keep treating because the organs aren't responding, but treating with chemotherapy or plasma cell-directed therapy isn't necessarily needed once you have a complete hematologic response, just because the organ has not yet improved. So here I show the hematologic and organ response criteria, and we talked about the hematologic response. And in terms of organ and renal response, you see patients who achieve a hematologic response, which is a decrease in the cardiac biomarker by greater than 30%, do best. And patients who achieve a renal response, meaning their protein loss in the urine decreases by greater than 30%, have a really low risk of requiring dialysis. So what's the standard of care approach before now? I just wanted to start with patient RS to highlight several different important points when thinking about a patient's journey through their diagnosis and treatment with AL amyloidosis. So patient RS came to medical attention with progressive muscle aches and intermittent numbness to tingling that really developed over years. She was first seen in 2009, and then her symptoms continued through 2011. And in mid-2011, she sought treatment with a rheumatologist and was diagnosed with polymyalgia rheumatica. She was started on steroids with some improvement. Thereafter, about 9 months later, she developed exertional chest pain, which landed her in the emergency room. And her EKG showed normal rhythm. Her stress test didn't show what we usually see in patients with coronary artery disease, and that's ischemia. Her echo showed mild hypertrophy and a normal left ventricular ejection fraction, which is how we usually diagnose heart failure. But she also had this very high cholesterol despite being on lipid-lowering medication. However, it wasn't until June 2012, a few months later, when she started to develop lower extremity edema, that she was identified to have nephrosis and ended up in the nephrologist's office and had a renal biopsy showing lambda light chain amyloidosis. It was then that she came to MSK in July of 2012, 3 years after her initial symptoms started to develop. She had a low albumin in her blood. She had a high free lambda light chain. She had abnormal cardiac biomarker and 6 grams of protein in her urine. A cardiac MRI suggested amyloidosis by this pattern called diffuse late gadolinium enhancement, and her bone marrow indeed showed 10 to 15% lambda restricted plasma cells, as well as the amyloid in the bone marrow. So finally, she was diagnosed with cardiac stage 2, renal stage 2, lambda light chain amyloidosis. And so how are we going to treat this woman? Again, our first step is to eliminate the pathologic plasma cells. And back in 2012, there were not much treatment. There were very little treatment options. And in patients who could tolerate it, we used high-dose melphalan with a stem cell rescue. And what I wanted to share with you is it's really kind of a misnomer to call it an autologous stem cell transplant, but it was developed out of treatment that was being used for patients with multiple myeloma. What it really means is that it allows you to deliver very high doses of chemotherapy. So the way it works is that patients have stem cells collected. Stem cells are blood, normal, healthy blood-forming cells. They're collected and frozen, mobilized by growth factors or chemotherapy, put in the freezer, and that allows us the ability to deliver high doses of chemotherapy, in this case melphalan, and then we use those stem cells. It's not to fight against the cancer, but it's to rescue the bone marrow because this melphalan is toxic against the abnormal pathologic plasma cells, but also your blood cells, and then these cells rescue the bone marrow. And this is one of our most effective therapies, but only 25 to 30%, maybe up to 35% of patients are eligible for this high-dose treatment. We tried to make this more tolerable by risk adapting the melphalan dosing based on age, kidney compromise, and cardiac involvement, and using different doses of melphalan, followed by transplant. We restage patients after 3 months, and those who had a complete hematologic response, which is about a third of patients, were observed because these patients have a very durable, lasting response. However, those who had less than a complete hematologic response were given consolidation, and we found that after a series of trials, when we used bortezomib or Velcade as consolidation, we could improve the complete hematologic response rate by double, almost 60%. And so the next question was, can we use bortezomib up front if it led to such good responses? And indeed, we did a pilot study of bortezomib and dexamethasone before and after risk-adapted high-dose melphalan and stem cell transplant. And this is what our patient was treated with. So this is our patient, and I show here her circulating, a measurement of her circulating free light chains. This is measuring her free light chains, and in between these dotted lines is the normal range. So initially she received Velcade and dexamethasone induction, and she went into a very good deep response, which was followed by a stem cell transplant and consolidation. And she last received therapy in 2014 and remains in a complete hematologic remission, although you can see that we're watching her closely because her numbers are trending up at this point. And just to understand the limitations of our hematologic disease control when it comes to organ improvement, we see that here in 2013, she had greater than 5 grams of protein, and this is when she achieved a hematologic response, but it really wasn't until 2016 that her protein actually went away. And the same is true for her cardiac disease. She had a high elevated BNP level, which actually got worse during transplant, which is not uncommon because your body's under stress. And then once she went into a complete hematologic response, it took time, but overall her biomarkers have improved. And again, the goal would be to treat her if her free light chain is really rising before she has any organ damage. So the choice for upfront therapy through 2020 was really risk-adapted stem cell transplant for patients with with low burden of plasma cell disease in the marrow and a good performance status, whereas bortezomib-based induction is our standard of care, namely with bortezomib, Cytoxan, and dexamethasone, which is preferred in patients with renal compromise, but often is not as effective in patients with translocation 1114, which is something we'll talk about in a bit. And our high-risk patients can't really tolerate either of these options, and we have to attenuate the doses of our treatment and support them with intensive supportive care, oftentimes in the hospital or with very close monitoring, because again, when the organs are compromised, patients need to be supported even when they achieve a complete hematologic response. Moving forward, in 2021 has been an exciting year for us who focus on AL amyloidosis, because daratumumab is an anti-CD38 antibody, which is a marker on plasma cells, and it was approved for the treatment of multiple myeloma in 2015 because it targets the plasma cells and it induces cell death, and led to great responses in that disease. And so therefore, it was tested in heavily pretreated patients with AL amyloidosis. And you can see here, similar to what I showed you before, this is a measurement of the free light chains. This is the normal range in blue, and the purple is these are 3 different patients who have elevated serum free light chains. And in this patient, they've never normalized. They went up and down with different therapies. This patient had somewhat of a response, but then relapsed. And this patient was refractory to all treatments that had ever been delivered. And once they got daratumumab, they went into a rapid and complete hematologic response, which was very encouraging. And so a phase 2 study of daratumumab in 18 patients, the initial 18 patients were presented in 2018, and we saw an 89% response rate with an 80% very good partial response rate. You can see that this is the percentage of decrease in their circulating light chain, and you can see even after 1 dose of daratumumab, the reduction in the free light chains were dramatic. So the phase 2 study in its mature form was published, and the daratumumab in these relapsed refractory patients led to a 90% overall response rate, with upwards of 80% of patients achieving a VGPR. And this data led to the Andromeda trial, which is a trial that includes patients treated with the standard of care, cyclophosphamide, bortezomib, and dexamethasone, with or without the anti-CD38 antibody daratumumab, and these are newly diagnosed patients. This was a large randomized phase 3 trial in which one arm of the trial, the patients got the Cyber-D alone, and the other arm of the trial, the patients got Cyber-D plus Dara. After 6 cycles, the patients who had the Cyber-D plus daratumumab went on to receive daratumumab as maintenance therapy with a dose every 4 weeks for a total of 2 years. These patients were observed, and these patients, after 24 months of therapy, were also observed. So the duration of treatment was not exactly comparable, but this is how the trial was designed. And the primary endpoint was complete hematologic response rate, which is very appropriate. That's our goal of therapy. And our secondary endpoint was this combined endpoint of major organ deterioration, PFS, which I'll explain, the organ response rate and time to response, as well as the safety of this regimen. So in the initial 28 patients who were treated, just to make sure that this was safe, saw very encouraging results with a 97% overall response rate and greater than 50% complete hematologic responses, as well as very high rates of organ response in small numbers of patients. And the overall responses, the overall result of the clinical trial was presented this past December at ASH in 2020 by Dr. Comento, and you can see here that the trial met its primary endpoint, and the complete hematologic response in the patients who received the DARA-VCD regimen was almost 60%, almost a tripling of the complete hematologic response rate when compared to the VCD alone. And this modified PFS was defined by death, cardiac deterioration, end-stage renal disease, or hematologic progression. So anybody who achieved any of those endpoints was considered a progression event, and you can see that it was much more frequent that it occurred in the VCD arm versus the DARA-VCD arm, at a frequency of, you had a 42% risk, higher risk of achieving one of those endpoints if you did not receive daratumumab. So this was a very positive trial, and it led to the historic approval of the first and only treatment for AL amyloidosis on January 15th this year, which is a huge step forward for us as treating physicians as well as for our patients. So here I present another patient so you can again appreciate the patient's journey. And QD is a young, previously physically active man who became short of breath in July of 2019 to the point where he had to stop going to the gym. He was hospitalized in April 2020. Of course, they thought he had COVID, but he was COVID negative, so they treated him for asthma and pneumonia. He was also noted to have fluid on his lungs, and he was given water pills. And he got better for a little bit. By the end of the summer, he was unable to ambulate even 20 yards, which led to a cardiac evaluation, and again, a nuclear stress test, which we used to look for coronary artery disease, didn't find any ischemia. So he was sent back to the pulmonologist, who optimized his asthma regimen and drained some fluid from his lungs, but he still didn't feel well. So he sought out a second opinion from a different cardiologist who did an echo, which showed both a very thickened heart wall and a low ejection fraction, an abnormal EKG, which was appreciated, and the cardiac MRI, again, had this diffuse subendocardial late gadolinium enhancement, which was suggestive of amyloidosis. He came to MSK in December of 2020, again, 18 months after his initial symptoms, more than 18 months after his initial symptoms started. He also had an elevated free lambda, very abnormal cardiac biomarkers. His echo was abnormal, as it had been on the outside, and his bone marrow showed 10% lambda-restricted plasma cells. No evidence of amyloid could be proven there. He did have a translocation 11 1114, which occurs in about 50% of patients with AL amyloid, which is much more frequent in patients with amyloidosis than it is in patients with myeloma who have who plasma cells harbor the translocation 1114 in about 15 to 20% at diagnosis. So we had a high suspicion for amyloidosis based on his clinical syndrome, cardiac biomarkers, free Landau light chain, and bone marrow. And we did a fat pad, and that was negative. And ultimately, he got a heart biopsy and was diagnosed with Landau light chain amyloidosis. So he was Mayo's cardiac stage 3A Landau light chain amyloidosis and started on a program of Cybor-D plus DARA, which has a favorable outcome in patients with translocation 1114. So in the year 2021, this would be the upfront treatment of choice, especially in somebody with cardiac stage 3A disease, although higher risk patients who have cardiac stage 3B disease, you might even consider single agent daratumumab with intensive supportive care, and risk-adapted stem cell transplant, still reserved for patients who are quite well and have a low burden of disease. And then, so not everybody responds to our frontline therapy for AL amyloidosis, or the potential is there for patients to relapse, and therefore we need second-line treatment strategies. In terms of when to treat, when somebody has not achieved a response, we go on to second-line therapy. But then when somebody has responded, like in our first patient that we looked at, and then the free light chains start to creep up, we call that a hematologic relapse. Progression means they meet a certain threshold, and it's hard to know exactly when to treat patients because, again, we want to spare them the toxicity of any treatment, but not let them develop any organ damage. So the first question when somebody is relapsing is, are the organs okay? We don't have good guidelines in telling us when exactly to pull the trigger for to retreat in the second-line treatment. But the good news is that there are now treatment options. And here I show you a chart of the FDA-approved treatments for multiple myeloma, which is where we borrow all of our therapies from. And you can see here the proteasome inhibitors. In black are all of these treatments have been approved for multiple myeloma. In black are treatments that have been studied in light chain amyloidosis. We talked about bortezomib. Ixazomib is an oral proteasome inhibitor that's been studied in the second-line therapy and has been shown to be effective in that case. Carfilzomib is a second-generation proteasome inhibitor that is quite effective because it inhibits the proteasome in a non-reversible fashion. But this has only been studied in patients without advanced heart disease because carfilzomib has a cardiac toxicity signal. The IMiDs or immune modulating drugs are shown here. All are approved in multiple myeloma and have been studied in amyloidosis, where pomalidomide is currently being studied. So in orange, I'm showing you the drugs that are currently in active trials in amyloidosis. These drugs also have are associated with responses in light chain amyloidosis, but have limitations. Namely, thalidomide has been associated with neuropathy, and both lenalidomide and pomalidomide can be associated with a cardiac toxicity signal, meaning we see patients who are on these drugs who develop worsening of their or increasing cardiac biomarkers, and also can have clinical heart failure. The alkylating agents, where melphalan was the standard, include bendamustine, which has been studied in amyloidosis and has a response signal. Cyclophosphamide we talked about. Propylene glycol-free melphalan is a interesting drug because it allows us to deliver this melphalan in a very strategic way. We have a program where we do pharmacokinetically dosed melphalan in order to limit the toxicity and improve efficacy with this drug. Melflufen is also a novel agent where it is a drug which gets delivered directly to the abnormal plasma cells and has had activity in multiple myeloma, is currently being studied in light chain amyloidosis. Daratumumab, we talked about, the first and only drug that is FDA approved and available for patients with amyloidosis. Isatuximab is another anti-CD38 antibody that is being studied in amyloidosis and has fairly comparable response rates to daratumumab where, in the second-line setting. The issue is whether or not this is going to where this drug is going to develop is still a question because all of the data that is surrounding daratumumab and the FDA approval. This one's kind of the second anti-CD38 antibody to be developed, and but hopefully this will give us more treatment options in the future. Elotuzumab is an antibody that is against PS1, another marker on the plasma cell surface, and this is being studied in clinical trials. And the most exciting piece of information I think that I wanted to share with you are all the novel targeted therapies and novel immunotherapies and the amyloid-directed therapies that are being developed in this disease. I hope this gives you hope for the future because we'll talk a little bit about venetoclax, whose target is BCL, which is a BCL2 inhibitor, which has activity in this translocation 1114 population. Selinexor has a different mechanism of action and it's being studied. It's been approved in multiple myeloma, now being studied in amyloidosis. These antibody drug conjugates, this group of novel immunotherapy really is very exciting. This has, belamaf has been approved in multiple myeloma, and there's at least some emerging data that it is going to be effective in amyloidosis, and the trials using this drug are currently being done. This is another antibody drug conjugate. That means that it binds to either BCMA or anti-CD38, and it delivers a drug directly to the abnormal plasma cells. This is currently being studied also in amyloidosis. And lastly, when you get rid of the hematologic disease and you're still left with organ impairment, we really have no therapy that actually is directed against the amyloid that's currently deposited in the tissues. And so amyloid-directed therapies are being studied. The first one was NEOD-001. This was studied in randomized studies that were negative, although there's some emerging data that in at least a subpopulation, this may be effective. SCALE-101 we'll talk about more, also an anti-light chain antibody. It binds to the light chain, similar to NEOD-001, and it incites your own immune cells to get rid of the amyloid that's already present. And at least in mouse models and at least in some human studies, there is some evidence of efficacy that the organs will improve when given, at least in the phase 1/2 trial, that these organs can improve after receiving treatment with KL101. Doxycycline is an antibiotic and it stabilizes the fibrils. It's been used as prophylaxis during transplant and was seen in patients who had doxycycline did much better and may be of value, especially in patients with cardiac disease. However, with the emergence of all these drugs and really not a good understanding of what's best and how best to use them, and limited availability, when available, I think treatments should really be given in the context of a clinical trial. That's the only way we'll study them in a systematic fashion, be able to understand the toxicity, be able to understand the efficacy, and ultimately lead to FDA approval of these drugs. So looking at relapsed patients, specific populations, I mentioned that 50% of patients with AL will have their abnormal plasma cells will harbor the translocation 1114. These patients tend to have a poor response to bortezomib-based therapy. But patients with this translocation, as first shown in patients with multiple myeloma, are uniquely responsive to this BCL2 inhibitor called venetoclax. And recently, a retrospective study showed that included 27 patients that with this oral therapy, 78% of patients achieved an optimal response, a VGPR or CR, which is very exciting. Other therapies that are available outside of a clinical trial for relapsed patients, daratumumab, now that it's approved, certainly if a patient was treated with something else before the approval of daratumumab, if they're relapsing, daratumumab has a very high efficacy as a second-line therapy, as I showed you, and sometimes we use it as a single agent or in combination. And again, in patients who improve their organ function with their frontline therapy and are in better shape, as patients often are during their second-line therapy than they were in their first-line therapy, they may become eligible for high-dose melphalan and stem cell transplant. So how are we going to improve care for AL patients moving forward? One of the most important initiatives is to facilitate earlier diagnosis. In truth, if we continue to miss the diagnosis and patients present with advanced organ disease, it doesn't matter how good our drugs are, we will have a very hard time improving patients' outcomes. So one of the things that we and others are doing are really working on educational initiatives to spread the word about awareness about this disease and speak to people in the community about the ways to recognize and diagnose the disease. Also with my colleagues from Tufts, we did an interesting trial where the SAVE trial, seeking amyloid very early. There are certain sequences of the free light chains that have a propensity to develop amyloidosis, and if we can actually screen patients with precursor disease, MGUS, or smoldering myeloma, and find out what their sequence of their light chain. Perhaps moving forward, we can identify patients even before they develop significant clinically relevant disease. However, we know that patients will still present with organ dysfunction, and there are initiatives to hasten organ improvement. And really, what we're very excited about is these anti-light chain antibodies, namely the Scale 101 is now in 2 clinical trials where the new standard of care, Daracibor-D, is being studied with or without this anti-amyloid antibody in very advanced cardiac stage 3A and 3B patients who really need help in terms of facilitating their organ improvement in a rapid fashion. When we just can't, when the organ function is too advanced and there is no way to improve organ disease, which certainly happens, we are now really focused on replacing organs that fail. And with colleagues from 6 different countries, we put together a large international experience of our kidney transplant patients, which really shows excellent outcomes and suggests that anybody who has end-stage renal disease, is requiring renal replacement therapy, or is at risk of developing end-stage renal disease, who have achieved a good hematologic response, meaning greater than VGPR or better, should be considered for renal transplantation. It has also been recently published that patients who receive heart transplantation for AL amyloidosis the outcomes are actually similar to other indications for heart transplant, which was not the case in the past before we had good plasma cell-directed therapies. In summary, in terms of diagnosis, the disease remains under-recognized, which leads to late diagnosis, which clearly has implications for organ disease and prognosis. And the most important thing for practitioners is to think amyloid. If this is unrecognized and not even considered in the differential diagnosis, patients will continue to present with advanced disease. And so that's my message to anybody I speak to in the community when doing educational initiatives. I think that's how we can really save lives. So rapid hematologic disease control, as measured by the free light chain response, is the first goal of therapy. And we're very fortunate that daratumumab is the first FDA-approved drug for this disease. Organ responses follow the hematologic disease control, but can take months to years. And treatment should not be continued based on persistent organ disease alone. When organ dysfunction persists despite a hematologic response, organ transplantation could be an option, and now we're very excited about the prospect of anti-amyloid therapies. The good news is, and I feel like we should all have hope moving forward, because novel targets approaches are finally studied in this. It's taken a long time to get here, but I think it's a very exciting time, and really the future is looking bright for amyloid patients. Thank you very much.
As a reminder, text chat is located on the right-hand side of your screen. To submit a question, type your question in the small text box at the bottom, and when finished, click the send button. Please note that due to time constraints, our speaker may not respond to all questions submitted.
Hi, this is Heather Landau. Thank you for having me. I will start with the first question. I'll read it aloud. I had amyloidosis 6 years ago, still losing 6 grams of protein in 24 hours. Is this something you see from time to time? Is there anything I can do about it? would you recommend another kidney biopsy in view of this? Is a low protein diet recommended? Is exercise with weights okay with all this protein? My total protein is 4.8 and cholesterol is high. I guess the first question is whether or not you have achieved a complete hematologic response. And by virtue of normalizing the serum-free light chains, and now we even talk about this minimal residual disease, which is what MRD stands for, which is not very well defined in amyloid, but as a standard, we look at the plasma cells in the bone marrow to see if amongst 5 million, depending on the sensitivity of the assay, 3 million or 5 million cells, can we detect any abnormal plasma cells? So if your disease is the hematologic disease is under control by virtue of having a normal free light chain, involved free light chain, and no paraprotein detected by serum protein electrophoresis, and no abnormal plasma cells in the bone marrow, and you still have organ disease or proteinuria, it may be because it may not be because of ongoing amyloid deposition, but really that the kidneys are unable to recover. So it is something that we do see from time to time. I don't know that there's anything we can do about it. There's some medications that are thought to reduce the amount of proteinuria, but they also have other side effects that can be detrimental for amyloid patients. These are the ACE inhibitors or the angiotensin receptor blockers, that class of medications, but often patients with amyloid have low blood pressure, so they're not well tolerated. Another kidney biopsy, if there is another potential indication, another potential etiology of proteinuria, it wouldn't be necessarily unreasonable, but I would expect it to still show amyloid if amyloid was the initial insult. But if there is somebody that has diabetes or if there's some autoimmune disease, I don't think it's unreasonable if the hematologic disease is well controlled to repeat a kidney biopsy, although there's always risks with any invasive procedure. I don't think that there's any problem exercising with weights, and I don't think that, and I think your cholesterol should be treated. Next question, how long does it take an organ to respond? That's a loaded question, but I often tell patients we can control the hematologic disease pretty rapidly in certain circumstances, but it really takes months to years for the organs to improve. And again, it's not a guarantee. So the more advanced the organ dysfunction is, it may take longer or it may not be capable of improving. But patience is definitely needed in after treatment. Please define MRD and what clinical parameters are used in assessing. I assume there are normal levels of free light chain, so what additional tests are used? So yes, so the standard hematologic response criteria rely on the serum free light chain levels predominantly, but a complete hematologic response also relies on the serum protein electrophoresis assay and immunofixation, which is another way to detect the disease in the blood. But in the related condition, multiple myeloma, where the bone marrow is usually full of lots of plasma cells, MRD testing has really relied on different tests such as next-generation sequencing, which is a molecular test, or flow cytometry, which is a cell-based assay where they look at, again, this is very sensitive methods of detecting abnormal plasma cells in a bone marrow specimen. So when we talk about standard MRD, minimal residual disease assays, we're usually talking about bone marrow-based flow cytometry or next-generation sequencing. However, in amyloid, because the pathologic protein is not necessarily the plasma cells themselves, but the circulating light chain, there are attempts to define MRD by more sensitive methods, to detect minimal residual disease by more sensitive methods than just the serum-free light chain assay, by a technology, one of the main technologies being used is by mass spectrometry, which really identifies, is a proteomics-based assay. It really identifies the protein. We can also use next-generation sequencing in the blood. All of these tests have their limitations, unfortunately, have their pluses and minuses. It would, however, be great if we didn't have to do bone marrow tests on patients in order to define or to identify so-called minimal residual disease. Next question. My father had AL amyloidosis in 1985 and died due to renal and cardiac arrest in about 12 months. I've been watched with MGUS since 2009, was diagnosed with IgG lambda multiple myeloma and renal involvement last year, began treatment, and have had a VGPR to CR as of August 2021. Congratulations, using Dara, Velcade, and dexamethasone. My 2 prior biopsies have been negative for amyloidosis and only positive for multiple myeloma. My question is, could amyloidosis be present in an organ without being present in the marrow, requiring me to have a renal biopsy at some point to be sure? Yes, the bone marrow is only in patients who do have amyloidosis in their organs or organ involvement with amyloidosis and abnormal plasma cells in the bone marrow. The bone marrow will show amyloid. Amyloid will be present in the bone marrow in about 60% of patients. So the absence of amyloid in the bone marrow doesn't mean absence of amyloid in the organs. When you say that you had IgG lambda myeloma with renal involvement, the way that myeloma affects the kidney is very different than the way that amyloid affects the kidney. So in myeloma, the light chains, there's a distinct difference. So in amyloid, the pathophysiology is that these light chains misfold into the substance called amyloid and deposit in a specific part of the kidney, usually the glomeruli, and lead to protein loss. Whereas in myeloma, the light chains do not misfold and they don't form the substance called amyloid, but instead the native protein, the native light chain, clogs up the tubules of the kidneys and cause renal insufficiency. So if there is a suspicion for amyloid based on the clinical syndrome, a kidney biopsy would be warranted in somebody who has an IgG lambda plasma cell disorder. So I think that it really depends on the manifestations of both your plasma cell disease and your renal disease in order to see if it's necessary for a organ biopsy. Often sometimes we use surrogate sites, so the other more readily available tissue that can be biopsied would be a fat pad. There is a question of what is VCD. VCD is Velcade, is a standard term we use for the combination of Velcade, Cytoxan, and dexamethasone. There is a question about the duration of therapy of daratumumab for 1 year or 2 years. Well, that's a good question, but we really have limited data. The recent approval from the Andromeda study, which studied 6 cycles of Cybor VCD plus daratumumab, followed by daratumumab maintenance versus VCD alone, continued daratumumab for 2 years. It's not like there was an arm of the study that had VCD plus DARA as 6 cycles without any maintenance, or VCD plus DARA with daratumumab for 1 year, or VCD DARA plus DARA for 2 years. So we have no comparison between those 3 situations, and so I can't really, I'd be guessing to tell you which one is better. We do know that based on some data in the relapse setting, my colleague Vaishali Sancharwala, who did the phase 2 study of daratumumab for patients with relapse disease, continued the daratumumab for 2 years, and our European colleagues did, in the same patient population, delivered daratumumab as single agent for 6 months, and the outcomes appear to be better in the U.S. study, but what the optimal duration is really, without a comparison, the optimal duration is really unknown. Can Darzalex cause pain around the torso, or is it more likely to be disease-related? The injections, it really depends. Some people tolerate the injections without any discomfort, and some people bruise and have discomfort. I don't know that skin discomfort that occurs after injections with Darzalex would be disease-related. So I think it's always a possibility when you stick a needle in tissue that causes pain. Sometimes patients with neuropathic manifestations of amyloid can have more pain. So I can say that Darzalex may be the cause of pain around the torso. Are there any studies about the application of CRISPR to AL amyloidosis? Yes, there's excitement about using CRISPR to treat patients with hereditary variants of this disease. To my knowledge, there's not one gene that we know that it's this AL amyloidosis is much more heterogeneous. So to my knowledge, there's not any data on CRISPR in AL amyloidosis. Where, if at all, does venetoclax fit into the treatment options? Again, it's being studied in patients with translocation 11:14, and we're excited about this possibility. The studies have, I think I showed some data in the relapse, anecdotally, in relapse patients that was generated retrospectively. Prospective studies are planned and hopefully will be up and running soon. But I think anecdotally, this has been an effective therapy for our patients with AL amyloidosis with translocation 1114, as it has been in patients with multiple myeloma. If you have a CR from CyBorD plus DARA as first line, could it make sense to delay transplant until relapse? Well, that is the most important question that patients and investigators have in this field. So really, I think that there's a lot of evidence to suggest that patients who achieve a complete hematologic response do well regardless of how they got there, so agnostic of their treatment. The durability of response with CyBorD, so the good news is that with CyBorD plus DARA, the complete hematologic response rate is upwards of 50%, which is similar to what we see with transplant in the frontline setting. If we then added on transplant, I'm sure we would get more patients to a CR. So in patients who have less than a CR, I think transplant is definitely indicated in that patient population. The big question is whether or not the patients who achieve CR with this therapy also benefit from going on to transplant. The data, the issue is that patients who achieve a CR to transplant, the durability is known, meaning we have long-term studies that show patients who get to a CR with an upfront transplant really have a very, very long progression-free survival and overall survival. And so that is a really valuable benchmark to achieve when it's from transplant. I can't say that it's going to be different if you get a CR from CyBorD plus DARA. My bias is if you get a CR from CyBorD plus DARA, but you're at risk of toxicity from transplant, then I think delaying till relapse makes sense. I think patients who are well and can tolerate transplant, it has to be a discussion between you and your doctor. In that setting, no matter what, if you are a potential transplant candidate, I would definitely collect your stem cells after, once you have a response to CyBorD plus DARA. I wouldn't not throw out the transplant, but I think it has to be a discussion between the patient and their doctor, understanding that there is no data to drive to determine what is best in this setting. Do you think daratumumab is an alternative to bone marrow transplant? Again, I think I just answered that question. It depends if you have a daratumumab-based therapy and you don't achieve a complete hematologic response, I think it would be my bias to go to stem cell transplant. If you do achieve a complete hematologic response and there's a reason not to go to transplant, I would not have the patient go to transplant, and then there's this gray area for the rest of the patients. How does a patient get tested for translocation 1114? That's a bone marrow-based test where we look at the plasma cells, and we do this assay called fluorescent in situ hybridization. It's usually done on an initial bone marrow test, and it's pretty standard of care in hematologic practices. How is translocation 414 affected by drugs in development? I'm not sure that in amyloidosis we know that. We know in multiple myeloma, these translocation 414 responds favorably to the proteasome inhibitors, which are commonly used in AL amyloidosis, namely Velcade, as well as carfilzomib. But the specific response of patients who harbor translocation 414 to the novel drugs that are being studied is, I don't have any data on that. When are CAR T cells or BiTEs going to have clinical trials for AL amyloidosis? I think that is coming. Again, I think that we have to balance the toxicity of these treatments with the patients who are often compromised and have multi-organ involvement with amyloid. I think may have higher toxicity than the patients with multiple myeloma. I think these are very effective strategies compared to other salvage therapies. However, the investment is real, and the durability is clearly unknown. So while we're excited to have new therapies to study in AL amyloidosis, I think that we're still working out the role of these therapies in patients with multiple myeloma who tolerate such therapies better. And I think it's a kind of moving landscape of when and how they'll be studied in patients with amyloidosis, but I do think we'll get there. Is high cholesterol due to liver involvement? I have AL and I'm on 80 milligrams of statin due to super high cholesterol, but currently in complete hematologic response, I think. So high cholesterol is actually not due to liver involvement, but it's actually due to, it's when patients have protein loss in their urine or high degrees of proteinuria. So kidney involvement by amyloid causes this protein loss in the urine, and then the liver compensates by making more cholesterol. So it's really not a result of what you're eating or your diet. It's really your liver trying to compensate for the lost protein in your blood and your urine. And so patients often who have renal involvement often have high cholesterol and need more than one agent to manage that high cholesterol. So maybe a statin, maybe other alternative therapies as well in addition to a statin. I'm 79 years old, kidney organ, chronic kidney disease. Is transplant viable? I think that transplant is not viable, but somebody who is older and has compromised kidney function is definitely at higher risk for toxicity from transplant. So with this, now that there's alternative medicines, which I went through in terms of the presentation, I think that my favored approach for a 79-year-old with compromised kidney function wouldn't be high-dose melphalan and stem cell transplant, most likely. My concern with a bone marrow transplant is that it may not work. What is the success rate in your patients who have this procedure? I think across the board, the complete hematologic response rate with a bone marrow transplant. So the one thing everybody should understand is bone marrow transplant or a stem cell transplant is really not, it's not the transplant, it's really a way to deliver this high dose of the medicine called melphalan, which was our first drug that had a objective response rate in this disease and remains one of our most effective therapies. But the complete hematologic response rate is in the range of 30 to 40%. So that's the best response. And then in patients who have less than a complete hematologic response, we often use novel agents after transplant, and we can get the complete hematologic response rates upwards of 60 to 70%. But it's not like if it doesn't work, then there's nothing else, because it's really just another line of therapy. I've been an amyloid patient since 2014 with raccoon bruising of the eyes and went through CyBorD and stem cell transplant. After 6 months, needed to go on maintenance treatment of Revlimid. Was stable for a while and needed to change from Revlimid to pomalidomide. I was getting some renal involvement, and my doctor collaborated with Dr. Comento, and he suggested to start on daratumumab and venetoclax, and within 1 month, my light chains went to normal, below normal. Do you like this regimen? My only thing is my IgG has been lower. Sounds like you got great advice from Dr. Comento, who is a titan in the field, and it sounds like you're in a great place. Hopefully your organs will start to improve now that you've had a hematologic response. I do like the regimen. Again, it hasn't been studied prospectively, and there's no approval for venetoclax, but similar to you, I've had patients who didn't respond to other treatments respond to this combination or venetoclax alone. I don't have any problem that your IgG has been lower, so understanding that all of our therapies are directed against our plasma cells, both normal and abnormal plasma cells, and because they're effective, they can lead, your plasma cells make your immunoglobulins, and because they're effective, your immunoglobulins can decrease. And sometimes that's associated with increased risk of infection, and sometimes it's really just a cosmetic problem, meaning that your labs don't look normal, but it doesn't clinically have any significance. So in patients who just have a low IgG level, that's expected from the therapies, and we don't necessarily do anything about it or worry about it. Certainly for the last 18 months, we've been living with masks and socially distant and not in crowds. So if this is a new phenomenon, once you go back out in the world, if that ever happens again, then you may be at higher risk of infection, but I wouldn't, I wouldn't change behavior because of that. I would, however, in patients who tend to get increased frequency of upper respiratory illnesses or prolonged or has severe illness in the setting of low IgG, or even with a normal level of IgG, we often do IgG replacement, meaning monthly IVIG supplementation. I think that your doctor, however, just by having low IgG, again, which is the goal of getting rid of the plasma cells, isn't necessarily an indication or doesn't necessarily mean that you will be getting frequent infections. So I think that the good news is that you've had a good hematologic response, and that's the first step to clinical improvement. This is, have any amyloid patients been dosed with Abecma CAR T cells? These patients were not, were excluded, I can't say for sure, but these patients with amyloid were actually excluded from the clinical trial that studied Abecma, and now Abecma is commercially available, but that availability has been, although the Abecma, which is the CAR T cell against BCMA that's been approved for multiple myeloma, is technically commercially available. It is not readily clinically available based on manufacturing and company-related holdup. So I can't say that I know that an amyloid patient has been dosed with Abecma to date. My protein levels were 12,100 16 months ago. They are now 3,300. Is this a good result? Also, if this level never drops, can I live with it? I'm assuming you're talking about your urine protein level, and I think that's a remarkable level. We say a 30% reduction in the urine albumin level is consistent with an organ response, so you clearly meet that criteria. More recently, in the collaboration with our colleagues from Mayo and several other centers, we have defined degrees of organ response, meaning an organ partial response and an organ no response and an organ complete response, and a 60% reduction in patients with proteinuria, a 60% reduction in their protein excretion is a very good partial response, and to a level of lower than that is a complete organ response, and that is correlated with overall survival. So I think that, yes, so by that criteria, you've met a kidney very good partial response, but again, that's not really standard criteria. This has just recently been studied, and it sounds like you are well on your way to having even a better response, but if you do remain with, sometimes there's still some detectable protein that never goes away, but I would say by virtue of the rapidity of your response from 12,000 to 3,000 in 16 months, that is very encouraging. I have TTR amyloid. I'm doing an infusion every 3 weeks of Onpattro, and I'm on pills of Vyndaqel. The amyloid has gotten to my heart, so the doctor did not want to do a double transplant. Should I try to get on the daratumumab also? No, TTR amyloid is actually a protein that's produced in the liver and is not responsive to daratumumab, which is a drug that's directed to abnormal plasma cells in patients with light chain amyloid. So the different types of amyloid, it's really critical to understand where the amyloid protein is coming from, and patients with TTR do not respond, are not expected to respond to daratumumab. I have been living with Waldenstrom's macroglobulinemia for 31 years with varying responses to 6 different therapies. Will that history affect my response to AL amyloidosis therapies? It sounds like you've had Waldenstrom's for a long time, and now you have developed amyloid as the result of your underlying Waldenstrom's, which is really the way we define the pathologic cells in your bone marrow. And it's not, it is true that patients with Waldenstrom's develop amyloidosis, and less frequently than patients with underlying plasma cells will be the cause of amyloidosis, because in Waldenström's, the pathologic plasma cells is generally a lymphocyte, so more like a lymphoma, which has features of plasma cells. And oftentimes they respond to similar therapies. Sometimes it's harder to find because they're not necessarily responsive to daratumumab because they're not strictly plasma cells, and CD38, which is the target of daratumumab, is not necessarily expressed on lymphocytes, so it's not a home run there. I would say, in my experience, sometimes patients with an underlying Waldenström's and amyloidosis are more difficult to treat, trying to figure out what regimen they can respond to, but by and large, stem cell transplant has been very effective, or high-dose melphalan has been very effective in these patients. Also, a drug called carfilzomib, if you don't have cardiac involvement, can be very effective in patients with an underlying Waldenström's. My brother is on Vyndamax. Are you familiar with it? Are you hearing good things about it? He currently has cardiac involvement. Again, Vyndamax has been approved for TTR amyloid, which is distinctly different from AL amyloidosis, and it was approved because of a decrease in deterioration of patients who are on it for TTR cardiomyopathy. So it is a good drug. I don't know that it reverses the cardiac damage that's been done, but it slows progression. How long can one have AL amyloidosis before tests reveal it's a problem? Is there any way to catch or suspect a relapse sooner? Again, patients can have AL amyloidosis for varying numbers of months to years before they're diagnosed in the initial setting, again, because it's so, patients often present with very vague symptoms, nonspecific, and because it's a rare disease, the practitioners don't often think about it. Once it is, so it can range from months to years before one gets diagnosed in the upfront setting. And then after you're diagnosed with AL amyloidosis, hopefully you'll be followed forever, and somebody will be watching you closely for relapse, although sometimes it never happens, which is the good news, but there is a way to catch it early with the serum free light chain assay, although in the relapse setting it may not be sensitive enough, and that's why we're trying to develop more sensitive methods of detecting relapse disease in the blood. And certainly one can suspect a relapse if there is any evidence of organ progression. My immunophenotyping shows no monoclonal immunoglobulin identified. That's good. I don't see another question from that. But when you say promising drug, to what extent will these drugs help? Really, in any one individual, it's really hard to say. But if we think about the daratumumab-based story, if we now have a drug that in the upfront setting added to our standard of care VCD puts upwards of 50% of patients into a complete hematologic remission, that's very promising. But It's not to say it helps everybody, because there's still 40+% of patients who don't achieve a complete hematologic remission, and that's why we're all wedded to finding, I think that I can say from my experience, all of the investigators who care for patients with amyloidosis are very invested in finding additional effective therapies for our patients, and the bar is getting higher with that kind of response rate in the upfront setting, but it's not everybody, and we certainly need alternative treatments. So it is a community of investigators who are really wedded to and committed to finding novel, treating patients, caring for patients, and not giving up on finding additional therapies for patients moving forward. If chemo-induced neuropathy is going to diminish, how long might it take following the discontinuation of Velcade? Again, Velcade-related neuropathy is real. It's often, it was even more common when we were giving Velcade as IV. Now that Velcade's given subcutaneously, we were giving it IV and twice weekly. It was very common and would be very severe. Now that we're giving Velcade once weekly with as subcutaneous dosing, I think that we are all very pleased to see that it's less frequent, but when it happens, it can still sneak up on you and be painful and debilitating. We often stop the drug, and unfortunately it doesn't go away right away, but really, I would say months to years again. It does get better. The pain does diminish over time, and sometimes you're left with something that people describe it as just annoying. But annoying is annoying. So I think that when patients go on Velcade, I do urge them to report any early signs of any numbness, tingling, or any neuropathic symptoms, and take them very seriously as soon as they start. I think that we all do, because they can escalate quickly. But most of the time, it diminishes over time, and not always go away completely, but definitely is manageable. And daratumumab be used as maintenance therapy for more than 2 years. I've been on it for about 18 months. It has not been studied that way. Maintenance in the setting of amyloidosis, which is usually a low proliferative disease, meaning that there's less of a burden of plasma cells in the bone marrow that are less proliferative and don't tend to relapse quickly or frequently the way that patients with multiple myeloma relapse. So in truth, patients who get a good response are usually taken off of therapy. We are now studying, I would say that daratumumab has been studied for 2 years. There's nobody who can say that you can't be on it for longer, but again, I think that there comes a time when you have to go, when you say, okay, we've had a great response, we should watch you off of therapy, because again, there's always a downside to staying on therapy versus coming off of therapy, meaning that we are suppressing your both normal and abnormal plasma cells, and which can lead to increased risk of infection predominantly. I had difficulty with stem cell harvest after 4 cycles of Cyborg D plus Dara. Has that been observed in your practice or studied? That is a great point to bring up, because I think that with Cyborg D, we don't really feel like this regimen is stem cell toxic, but I think that in practice, daratumumab, as added to our other therapies, either Revlimid, Velcade, and dexamethasone, or carfilzomib, Revlimid, and dexamethasone, other regimens that we use in patients with multiple myeloma, we have seen difficulty collecting stem cells when daratumumab is added in that setting. I can say that I've had difficulty in patients with amyloidosis who are getting Cyborg D Dara, because I think the other drugs that we're using for myeloma patients, namely the carfilzomib and the Revlimid, the IMiDs, are also make it difficult to collect stem cells. But I think that it is an important point, and it should be studied, and I am certain that these data are being collected. Is tafamidis a viable treatment for TTR amyloid? Yes, that's why it was approved. It's been FDA approved for TTR amyloid based on a decreased risk of progression. I received Dara during spring of 2021. At the same time, I received my COVID vaccine, and it seems the Dara affected my ability to mount an antibody response to the vaccine. Have you observed this? Yes. So I think we know that, again, daratumumab is effective against plasma cells. Plasma cells are the cells that make antibodies. And so if we're giving you plasma cell-directed therapy, it is not unexpected that you may have a dampened response, antibody response to the COVID vaccine. What that means clinically is still uncertain. You have to understand that the assays that we're using to test the COVID antibodies are really, just like this whole illness is actually novel and not well studied before the present. These assays that we're using to detect antibodies to the vaccine, again, are just being developed now, and the specific level of antibody response one needs to be effectively immunized against COVID is unclear. There's other factors in the immune system that may be effective. I think that the antibody response is one thing, and then there's memory B cell and T cell responses. The good news is that in the majority of patients, even in our patient population, patients who are vaccinated are not dying of COVID. So even if you may have a dampened response to the COVID vaccine, I can't say that you have no immunity, because we're not measuring these other immune responses, other factors of the immune system that are probably at work. We are, at least at my center, offering patients who are on immunosuppressive therapies a third dose, however. But again, and we're measuring these antibodies, but I think we'll be a whole lot smarter in a year from now when we understand what these antibody responses mean in terms of effective immunity. Again, I think the majority of patients who are dying of COVID are the unvaccinated population. Although in somebody who's on daratumumab, let me preface this, who, even if you're vaccinated, I still think it's warranted to be careful. However, not completely isolated, because I don't think that's good for patients either. I had a stem cell transplant in December 2020 and now on Darzalex and dexamethasone monthly indefinitely. Will I need to stay on this regimen for life? Again, patients with amyloid are not typically, we have no data to suggest that maintenance therapy after stem cell transplant, if you've achieved a good response, is necessary. If you have achieved a VGPR or a complete hematologic response, I don't know that keeping you on Darzalex and dexamethasone is warranted. I think that if you didn't have an optimal hematologic response, going on Darzalex and dexamethasone makes sense. But again, in all the studies, even in the relapse setting or persistent disease after initial therapy, the Darzalex was only continued at most for 2 years. And dexamethasone also is a double-edged sword in terms of some people think it makes them feel better, and sometimes it can make you feel worse. But long-term dexamethasone is not good. So certainly if you've achieved an optimal response, going off the dexamethasone makes a lot of sense. Is a cure possible in the next 20 years? It depends on how you define cure. I think that there are several patients who go into a complete hematologic remission, and once they do, they will not necessarily relapse, and they'll have the opportunity to die of something else. And so is that person effectively cured? I think that's actually happening now. But again, everybody has different responses to these therapies, and the durability of responses to these new therapy has yet to be defined. How often do relapses occur, and what is the typical timeline for a relapse? Well, again, the patients in the Andromeda study, we haven't been following long enough for them to have relapsed, which is good news. But in the patients, again, the most commonly studied regimen has been the stem cell transplant. The median time to relapse is about 4.5 years after that. But that means that a median means that 50% of patients will relapse before 4 years, and 50% of patients will relapse after 4 years, and sometimes we have patients who are out decades after a stem cell transplant. I think that it is very unclear how often relapses occur, and the typical timeline in the setting of CyBorD plus daratumumab. I've had a complete hematologic response. If the protein loss is going up still after 6 years, is this unusual? In that case, I would probably do a biopsy. But again, sometimes there is just amyloid present, and once amyloid is present, that incites other pathology in the kidney, and it's like a snowball effect, and the kidney has no opportunity to recover, even though you've gotten a complete hematologic response. I believe that is the last, and this is at the 1 hour mark. That is the last question I see. If there's no other questions, I hope this was informative, and I look forward to participating with you again.
Thank you, Dr. Landau, for that presentation. On behalf of the Amyloidosis Foundation, I would like to thank you for your participation in today's event. This concludes today's program. Thank you, and have a great day.